Hello, everyone. So as Janice mentioned, today I will be talking about the Community Early Start Denver Model Project. And more specifically, I will be talking about a field test that we ran assessing fidelity of parent implementation in a diverse and low-resource community. All right, so a little bit about autism and early intervention. So we know that behavioral symptoms of autism can be observed prior to 12 months of age. However, historically, children are not diagnosed until 4 years or later. So there's a pretty significant gap between when we're seeing these early risk signs and when children are getting diagnosed. And there is an increased intensity of early screening that's going on in pediatrics right now. And there's also an increased prevalence rate of autism, as most of you know. And so there are a significant number of families who are going to seek early intervention services for their children due to social and communication delays, and that's with or without a formal autism diagnosis. Furthermore, child poverty is a significant issue in the United States and obviously around the world. And when you look at this chart, you can see that there are a large number of states here that have a child poverty rate of 15% or higher. And we know that in these areas, children do not receive high-quality services, especially autism-specific services. So we have Part C early intervention programs, which are often the source of intervention in these areas. And Part C programs are federally mandated under the IDEA, so the Individuals with Disabilities Education Act, which entitles individuals with disabilities to a free and appropriate education. And specifically under Part C, children with developmental delays are entitled to services from birth to 3 years under this program. And in rural, low-income, low-resource, and culturally diverse communities, Part C services are frequently the only services that are available, so there's not a whole lot else. But unfortunately, the interventionists within these programs are not using ASD-specific interventions. So from research, we know that intensive ASD-specific early interventions are indicated for the treatment of autism. And what we mean by this is usually evidence-based programs that have been objectively shown to improve outcomes for children with ASD. And these are typically available in university research settings such as the Mind Institute, but not so much in these more rural and low-resource areas. So there's currently a need for high-quality ASD-specific interventions within community-based early intervention settings. So as you can imagine, there are some barriers to this. And so the barriers are both at the intervention level and at the Part C system level. So in terms of intervention barriers, they are things like the technical aspects of some of these evidence-based programs, the precision of implementation methods, and inflexibility of many of the models, so they can't really be adapted to different settings and situations. And at the Part C level, there are limitations on staff training, so there is not a lot of time and there's not a lot of resources to conduct extensive trainings. There are a low number of service hours that are provided for the children. So in many areas, children are getting only 20 hours of intervention a month, sometimes even less, as opposed to 20 to 25 hours a week, which is what is recommended. And there are also requirements for family-centered care and interdisciplinary services. And while these are great things and we want there to be family-centered care, a lot of times these evidence-based programs are not really able to adapt to that, or it doesn't fit with the model. So we have the Early Start Denver model, which was developed by Dr. Sally Rogers and her colleague Geraldine Dawson. And ESDM is really well suited to be adapted for the Part C system for several reasons. It uses developmental and behavioral strategies. So it's focused on relationships, and it uses the latest science in development and language. And there's also a lot of ABA strategies that are used, like chaining and prompting and fading and things like that. It's manualized. There's already a fidelity of implementation tool that is included in the model, so individuals who are using it can make sure that they're delivering it effectively. It can be parent-mediated, so there doesn't always have to be a therapist there delivering the intervention, but a parent can learn it and deliver it on their own. There's also an interdisciplinary orientation, so a whole team can really be involved in the delivery of the intervention, which is important. And then there's also a family focus. So the overall target of our current project is to figure out if we can get an intervention in low-resource areas that will change outcomes in these communities among low-resource and low-income families. And so in order to do this, we're trying to adapt the ESDM for use in Part C systems And in order to do this, we developed a website. And on this website, we are teaching the ESDM curriculum to parents and to providers. So the website is called Help is in Your Hands, and that's a very catchy title, and the idea is that it's really meant to be used on a smartphone. So we know that families, even in really rural areas, have access to a smartphone. So even if they don't have a computer or internet access, they have a phone that has like a data plan or something like that, so they can access our intervention. And so that's the idea, that it's right in your hands. So a little bit about what the intervention looks like. So for parents, there are 20 video lessons. So there are 5 different modules with 4 lessons each. And these lessons are narrated and animated, and there's very little text, so there's not a great amount of reading that's involved. And of the reading that is involved, it's very low level, because we really want this to be something that works for anyone. Anyone can pick it up and use it, and they don't have to have a high reading level, and things like that. The parents get help from their interventionist weekly, and they work through the 20 lessons within the visits that they have with their interventionist. And through all of this, they will do assessments to let us know if this helped them and if it helped their child. On the interventionist side, there are preparatory materials that are on this website, and everything is really based in adult learning science. So we're making sure that we're really teaching these things in the appropriate way so that these interventionists can learn the material. They also get 4 hours of an internet-based group training, and they also get peer supervision. They provide the visits to the families, and then again, they tell us if it helped them, the parent, and the child. So in terms of our research objectives, the first is to build this wonderful website, then to try it out in a field test, and then to teach it more widely in a pilot test, and then to measure it to determine the outcomes. So in terms of where we are right now, we are in the try phase, and we have finished building the website, and we're doing the finishing touches on modules and materials, and we have just finished running the field test, which is the major project that I have been involved in within all of this. So in terms of the field test, it's a single subject design, and we're field testing the materials, modules, and fidelity tools in order to determine if there are modifications that we need to make before we run the pilot study. So the primary hypothesis for this field test is that parents will exhibit an increase in average fidelity rating scores over time. And the secondary hypothesis is that children will exhibit an improvement in symptoms and skills over time. So a little bit about what we did. So participants were 3 early interventionists from a local Part C system, and also 3 families. So the early interventionists are the individuals within the community and within this program that typically carry out services. And they were responsible for recruiting families, for getting consent, for obviously delivering the intervention, and recording sessions and uploading them for us to code. In terms of the families, they were 3 families from the same Part C system, and the children ranged in age from about 18 months to 2 years. The children were pretty much nonverbal at the onset, maybe with a few imitated words, but generally nonverbal. And they had to be at risk for autism or show risk signs for autism in order to be in the study. So therapists provided parent coaching, and then parents delivered the actual intervention. So they learned the ESDM and were delivering these teaching tools to their child to deliver the intervention. And so in terms of video recordings, first we got a recording of a baseline session. So before they watched any of the material on the website, we just got to see what they would normally do in a session with their child. And then we got videos from the sessions that were focusing on a specific module from the website. And this particular module was focusing on attention on others, so getting the child to focus attention on others. And then fidelity coding was completed by a trained group of coders. So the fidelity rating system that we used is one that has already been developed and is in the manual. And so parents were rated on a 5-point scale across 13 content areas. And the content areas included things like use of the ABC model, instructional techniques, management of attention, transition between activities, joint activities and elaborating on those activities, so things of that nature. And then in terms of coding, they could receive anywhere from a 1, which is lack of an effective display of practices, to a 5, which is best possible example of this teaching behavior. And anything from a 4 and above is considered competent teaching. So in terms of what we found, this is parent 1, so the first parent in the study. And you can see that this parent's scores in fidelity increase across time generally, with a slight decrease at time 3, but not below baseline. So they're showing steady gains in improvement in fidelity scores, and these are average ratings across time, so we averaged all of their scores at each time point. This parent is also showing a decrease in variability in scores across time, which is also a good thing. So overall, this particular parent showed about a half of a standard deviation improvement in fidelity scores across time. And then we have parent 2. And it should be noted that for this particular parent, they did drop out of the study, and that's why they only have a baseline and a time 1 and time 2, rather than a time 3 or beyond. They had to drop out for personal reasons. From baseline to time 1, we don't really see much of a change, but from time 1 to time 2, there is a pretty significant increase in fidelity scores. And so this parent is showing about a 1 standard deviation improvement in scores from baseline to time 2. So again, that's pretty good. And then this is our final parent. So this parent actually had the lowest fidelity at the outset, but made a pretty significant improvement in fidelity scores. So again, this parent's fidelity scores are improving across time with a slight decrease at time 4, but again, not below baseline. And this parent's showing about a 2 standard deviation increase in fidelity scores. And again, variability in scores is also decreasing across time. So this is a plus. And I think the major thing to take away from all of this is that each of the parents that we were looking at, by the time they got to time 2 or time 3, they were at or almost at a competent level of teaching. So at about a 4, which is pretty good. This is only in about 4 weeks. So that's a really short period of time to make pretty significant gains. So what have we learned from all of this? So we are seeing some really promising results here. So these parents are showing improvements in fidelity scores. We also saw changes in child behavior over a short period. So we haven't analyzed the child data yet, but qualitatively we did see improvements in language and also improvements in attention. So that's also very good. One thing we did realize is that our current fidelity tool may require some adaptation. So again, our fidelity tool is looking at 13 different content areas, and we realize that within the modules that are on this website, they may not reflect all of those areas. So it may be that we need to adapt the fidelity tool so that it's accurately reflecting the things that they would show improvement in. And then finally, we figured out procedures that were efficient for data collection. So when we first got into this, we weren't getting exactly all of the things that we needed in videos, and so we figured out things that we need to be explicit about in terms of what we're looking for and what we need and what we need the therapist to do and not do and things like that, which is obviously very helpful for the next stage of the study. So the next thing is that we will be doing a pilot study. So we'll be teaching this more widespread, and then we will be measuring it. So we'll be doing a randomized controlled trial with at least 50 children and families in California, Colorado, Alabama, and Pennsylvania, so in low resource areas. And this randomized control trial will look at CESDM versus intervention as usual, so what they would normally get within their Part C system. So how might all of this impact children, families, providers, and communities? So it will provide an easy and effective intervention in parents' hands. So again, they don't always have to have a therapist there to deliver the intervention, but they can be doing it on their own. It will provide effective practices with low-intensity training and supervision for providers. So again, they will also be getting something that they can use, especially with children that are showing early signs of autism. And then it will resonate with local values, practices, and resources within the community. So I think the biggest thing here is that this intervention does not require great resources from the community. So there's not a lot of money that they have to shelve out or a lot of training or anything like that, but this is really putting something in their hands that they can use to deliver something that's really effective. So the idea here is that if we find that this intervention works, we can offer it widely for free to parents and interventionists. So that would be a really great thing. And then this is our research team. So obviously, research is always a group effort, so thank you to all of these lovely people. And that's the end.
Good morning. I'll have to let you guys know in advance that I have to run back to my patients after I'm done this, so not at all because I don't want to listen to the wonderful presentations from my peers. Today I'm going to be talking about intellectual and neurodevelopmental disabilities in the hospital setting. So as a clinical bedside nurse, I see these patients all the time. I work in the ICU, and so admissions are not infrequent at all. So my mission with being a part of the LEND program was really to find a way to improve care for these patients when they are in the hospital. The first step, naturally, to anything is a lit search. So looking at background of the rather slender body of research that does exist about patients with intellectual and neurodevelopmental disabilities in the hospital, they experience more frequent admissions, higher levels of care, and they have an increased likelihood of experiencing complications. This stuff kind of, just in looking at it, seems a little intuitive. I mean, a lot of the patients that I see have some chronic conditions, and like I said, it's not uncommon for them to end up in the hospital. But once I started looking at the literature, it was actually pretty impressive at the difference in terms of one study, actually, out of my home province in Canada. Individuals with intellectual disability were hospitalized at a rate of 6 times the rate of the general population, and that was after adjusting for age, gender, region, and disease prevalence. And that was with a study group of over 8,000 individuals with intellectual disability and looking at the entire general population of the province. So I thought that was a great example of just kind of the looking at everything as a whole. And then higher level of care, meaning ICU versus a general floor, they do require ICU care more frequently. But then higher likelihood of experiencing complications. So that includes hospital-acquired infections, hospital-acquired pressure ulcers, falls, all of these kind of nightmares that you hear about in the hospital setting, this population is more likely to experience. What else do we know about these patients when they're in the hospital setting? Healthcare providers struggle with how to effectively care for this population. So that's something that is in the literature as well as in my own experience. It's definitely apparent that providers struggle due to lack of exposure, knowledge, and training. And naturally, patients and families can sense that and they feel that. And as a whole, all of those things increase cost. The cost of stay was something that I've thought about a lot because in terms of implementing an intervention or program within UC Davis Medical Center, that is what is going to create buy-in from my administration. So that's something that's definitely on my mind. There was actually even one article from the early 90s out of New Jersey that discusses care coordination as an intervention, and that intervention managed to decrease the cost of hospital stays by half, which is really impressive. I thought about doing trainings, starting a committee, implementing some kind of intervention in the hospital, but I think really what it comes down to is implementing a sustainable program within the hospital, and that means really starting at the beginning. So my protocol title is a descriptive analysis of patients with intellectual and neurodevelopmental disabilities admitted at UC Davis Medical Center in a 2-year period. So that is every child, adult who is admitted based on a list of ICD-9 and ICD-10 diagnosis codes that we will pull to look at a lot of characteristics that I'll show you in just a moment. Inclusion criteria for the study was patients discharged from the medical center between January of 2015 and December of 2016 who have an intellectual or neurodevelopmental disability identified by an ICD-9 or ICD-10 code. Exclusion criteria was obviously not having an ID or NDD diagnosis, and for IRB approval reasons, being over the age of 89 was also an exclusion criteria. Clearly, a very big gap in this study that I was not able to kind of moderate for was patients who come in who don't have a disability diagnosis in their actual chart. So it's passed on in nursing report. We're like, yes, we know this patient has a developmental delay, but it's not actually listed as a diagnosis in their chart. And in this particular study, I can't really find a way around that, I guess, after talking with a lot of physicians and nurses throughout that. So I think that will be a pretty significant gap, but at least this will start us somewhere. This is kind of the slide that I wanted to spend the most time on. The data points to be collected, you can see kind of everything on the left is general demographic information. So admitting diagnosis, discharge diagnosis, age, gender, ethnicity, insurance, where they come from, if they're admitted through the ER, if they're transferred from an outside hospital because UC Davis has particular services, and then what unit they're admitted on. Everything listed on the right is what I want to spend a little more time on. These are what I identified kind of through my experience and multiple conversations and consults I do throughout the hospital, areas that could be really identify intervention opportunities. So the unit of discharge, if we have patients who are always discharged, these patients tend to spend more time on one unit, say they're always discharged from this one unit, that would be the unit I would want to focus on to increase nurse advocacy, nurse understanding of particular challenges with these patients and opportunities for improvement. Length of stay and ICU length of stay, that data in terms of the general population at UC Davis is very easily available, so I can compare this population to the general population pretty easily. Delirium and sedation scores is a very kind of ICU-focused thought. Delirium scores are something that we look at in patients who have maybe a breathing tube in or some other intervention that requires them to be sedated. So they're quantifiable measures of whether patients in an ICU setting are sedated but arousable versus confused and agitated. So it's that measurement of the appropriate level of sedation. I just want to kind of clarify that sedation is very different from general anesthesia. So anesthesia, you are completely out and having surgery. Sedation, we want you to be sedated enough to wake up for a neurologic assessment, but also be comfortable. So that level, particularly in this population, anecdotally, is very difficult to achieve. I found a couple studies that kind of talked about particular case studies of patients with autism or severe intellectual disability about how they managed that. But it's actually a really significant challenge. So that's something that I particularly want to look at in the context of autism spectrum disorder and if there's a quantifiable association, because it's something that we talk about a lot in adult and pediatric intensive care. Number 14 there is referrals, so social work, psychiatry, and developmental behavioral pediatrics. Those referrals, are we using those services? We have access to them. That's something that I think is huge in the medical center. I feel like a lot of times we focus a lot on the medical problem and not on the big picture. And then discharge disposition is, where do these patients go? Do they go home with family? Do they go home with a caregiver? Do they go to a group home? Do they go to a nursing home? Do they live by themselves with in-home support services? And if so, is that associated with readmissions and or diagnosis and properly managing their care? The last two, number of admissions in a 2-year time period, we use the term frequent flyer pretty regularly in the hospital. And so are people coming back for the same thing over and over? I mean, that's a pretty obvious incidence that you can tell that either our discharge teaching was ineffective or their primary care was ineffective or both. And then total cost of stay, again, that will be my, hopefully, administration buy-in, because these stays are expensive and these patients spend more time than they need to within the med center. Qualifying diagnoses. So this is kind of just a small look at the list of, I think, close to 200 diagnoses that I have. And I spent a lot of time with multiple people in this room going over that list and making sure that it's appropriate. So intellectual disability, ASD, global developmental delay, Down syndrome, cerebral palsy, and epilepsy with some exclusions is kind of just a general overview. There was an extra layer of challenge thanks to the ICD-9, ICD-10 codes, switching us over with that, and then adding the DSM diagnoses kind of on top of that, made for a lengthy process. But it was ended up with a pretty comprehensive list that hopefully we will miss as few patients as possible. I also decided to include a study subset of emergency department visits. So these are patients who presented to the emergency department but were not actually admitted to the hospital. That small subset is just looking at chief complaint, if they have an ID-NDD diagnosis, and then their diagnosis upon discharge from the ER. The kind of goal here was to allow some insight into if there are patients who are seen in the ED and sent home and then ended up being admitted later. And are there patients who are seen in the ED frequently for the same reason? Data collection is currently in progress. I'm working with our Clinical and Translational Science Center. I think they're probably annoyed with my emails at this point, but I'm slowly getting a whole lot of data, and I think 2 years of the entire hospitals combing through all of that data is a lot for them. So I will definitely keep the LEND faculty informed as we move forward.
All right, good morning, everyone. So my LEND project started with the idea that the graduate student clinicians of the training clinic in speech-language pathology over at Sac State would benefit from some kind of student-run resource program. So the goal would be to increase awareness of resources available here at the Mind and out in the community for the clients we serve with neurodevelopmental disorders in our clinic. So it was my experience as a third semester clinician that led me to recognize the importance of this kind of project. So third semester clinic is when most clinicians work with individuals with neurodevelopmental and related disorders. And one of the projects for third semester clinicians is to find a local resource, research it, develop a one-page flyer, present it to your peers, and then distribute the flyers with your cohort so that you can share that with your clients in your session. I realized that the LEND project would be the perfect opportunity to expand on that project because it would be awesome for our clinicians to have something like that available throughout the year. Finally, because I've been a part of both the Mind and the Sac State communities, I realized that we are basically neighbors, but many of my fellow clinicians have very little awareness of how the Mind can serve families beyond providing a diagnosis and opportunities to participate in research. So the goal is that in increasing the visibility and accessibility of resources available at the Mind and in our community, our students would be better able to share that information with our clients on a regular basis in their sessions, and in the process would also learn more about neurodevelopmental disorders, evidence-based practice, and family-centered care. In addition, there is also a need to have a variety of resources on hand for the families who come through our assessment clinic. So these are usually families who, for example, end up on the wait list because we don't have space in our clinic, but we want to connect them with resources in the meantime. So if you ask most of my fellow clinicians, what is the Mind? They can tell you that research happens here, that we have a lot of research based on autism. Some families can get a diagnosis here, there are lectures, and there are clinical services. But as you guys know, that is not even close to the whole picture of what the Mind Institute can do for our families. The bigger picture includes programs, experts in our resource center, and resources both online and on-site that are immensely helpful to the families that we serve at Sac State. There are also resources such as the Library of Mind videos posted online that clinicians in training can use to expand their understanding of evidence-based practice, neurodevelopmental disorders, and to hear the lived experience of the families and individuals who inspire the work that is done here. So when my LEND mentor, Dr. Blanton, and I first started to brainstorm for this project, we felt that there should be 3 key pieces. The first would be a resource bank of some kind for our clinicians, and we had originally been thinking perhaps a resource binder located in the clinician workroom. And this binder would have handouts, flyers, and summaries of resources, organizations, and local events that our clinicians could share with their clients in their sessions. I also wanted to include information for clinicians and families to learn more about neurodevelopmental disorders and evidence-based practice in general. So for example, spreading the word about Captain and the Mind Tip videos. The second piece would be to highlight a resource of the month and upcoming events, as well as core resources like the Mind Resource Center in a space that is regularly accessible to our clients, like the clinic waiting room. And the final piece, which we knew would potentially be the most challenging, but the most important, would be to find some student volunteers who could help maintain and update these resources, as well as lead some outreach and awareness events for our clinic and on campus. So some challenges and considerations. Regarding the resource bank, we knew that we had the model of the Mind Resource Center to help with content, but the form would be key for making sure that this was a sustainable project. So as I mentioned, we had initially been thinking of a resource binder in the clinician workroom, but soon realized that a binder is something that gets overwhelming to maintain, gathers dust, and gets forgotten. And although a student volunteer would be key to keep the project going, there are university and clinic policies regarding who can be in the clinic to provide such a service. In terms of form, our department has a currently existing model of a resource guide for our clients with neurogenic communication disorders such as aphasia. A student, Taylor Spencer, had created a PDF listing resources in the greater Sacramento area, and this PDF is located on the department webpage. So the advantage over paper is that this is something accessible not only to student clinicians, but also to the public. And we decided that a web-based resource bank that models this is the way to go, but we wanted to focus on a resource guide that provides information for individuals with neurodevelopmental disorders. The harder part, and the part we needed to get right before starting the project, would be the solution for our student volunteer. So our clinic coordinator recommended that we go to NISLA. Now NISLA, which stands for National Student Speech Language Hearing Association, is the national organization for undergraduate and graduate students in communication sciences and disorders. And luckily for me, Sac State has a very active and large chapter of NISLA. So our NISLA undergrads are very engaged in serving our clinic and our community. They are the ones who make all of our family clinic events and our outreach events possible. So I reached out to our NISLA officers, let them know about this project and how we would like to collaborate with them, and then waited with fingers crossed as they discussed and brainstormed exactly how they could assist with this collaboration. Now, luckily for me, their fearless leader is Dr. Heather Thompson. Some of you may already know her. She is a professor in our department at Sac State, but is also a LEND faculty member and was a LEND trainee herself. So she found a way to establish an ongoing collaboration between NISLA and the department's LEND trainees that would allow us to get this project off the ground and continue to grow it year after year. So towards the end of each spring semester, each group of NISLA officers interviews and selects new officers for the upcoming year. And of course there are, the president, secretary, VP, all the usual officer positions. But for the first time, this next academic year, we will have a NISLA Mind Institute liaison officer. And so this is an officer who will be responsible for partnering with me in this project and collaboration. So meet Ashley. She is an undergrad in her senior year in our department at Sac State. She started working in ABA a little over a year ago, and she also volunteers here at the Mind. So I'm very grateful and excited to be working with Ashley and Dr. Thompson. This is kind of the dream team for the first year of this project. In a nutshell, here is what Ashley's position requires. So first, it will be a recurring position, which is key for keeping this collaboration and this project going year after year. Secondly, there will be a training curriculum for each officer to complete, which sounds scary, but is just a selection of readings, videos, and required time spent in the Mind Resource Center. And this is to make sure that each officer is well informed about neurodevelopmental disorders and the Mind Institute. They will maintain and update the resources that are web-based and also those that are located in the clinic waiting room. At a minimum, we'd like for them to facilitate one outreach or awareness event per academic year with our NISLA volunteers. And this could be, for example, organizing volunteers to run an awareness campaign during Autism Awareness Month. We also intend for the officer to work directly with each LEND trainee each year. And finally, social media is how you get a grad student's attention. So at the moment, our graduate student cohorts have a closed Facebook group that we use to share resources and information with each other. And we're not very good at sharing information and resources regularly because we're so wrapped up in trying to survive grad school. So it would be key for our NISLA officer to be a part of those groups and to regularly transmit information about upcoming events and resources in the community for our graduate students. So our revised plan, we have, instead of a binder, a web-based resource bank based on our current model for our clinicians and our clients that would be hosted on our department webpage. We have our highlighted resource and event info in our clinic waiting room space, and finally the best revision, a NISLA officer to maintain and update those resources, facilitate outreach and awareness events, and collaborate with the LEND trainee to grow this program. So here's where we are and here is where we're going. This summer, Ashley and I are focused on getting content for both the waiting room and the web-based resource space. We've been meeting with Terry in the Resource Center, and we'll be meeting with LEND trainees who are also parents to get feedback and ideas and just to soak in their wisdom and experience. We're also experimenting with the training syllabus. I really want to make sure that I'm creating something that is helpful and not overwhelming for our students who will be taking on this officer position. August is the month for getting final department approval for the in-clinic and web-based materials in preparation for the start of clinic, which for us is September. So September is when we are aiming to have the resource guide posted and available, and we'll be keeping the LEND folks updated. So I just wanted to share some of the wisdom that I've gained along the way from the LEND, from being a grad student clinician, and from our families. So sometimes student clinicians assume that the resource we want to introduce might be old news by the time that a family sees us. But my families have taught me that it does more harm to assume that they already know, and that it doesn't hurt to hear it again. The first time that they hear about the Mind Institute or Warmline, they may have been overwhelmed with information, and now that is just chicken scratch on a Post-it. No one's explained what that resource is or how they can get help. I've also learned from my mentors that when introducing resources, try to bring just a one-pager that answers the big WH question. So where is this resource? Who is it for? What will it cost and what kind of help do they give? And finally, how do you get in touch with someone? And surprisingly, in my experience, the one-pager that covers that information and isn't overwhelming for parents doesn't exist as often as you would like. So one of the goals of our resource bank is to create a brief profile for each of the resources that gets at those questions. And finally, Terry also reminded us that you need resources for the whole village because it takes a village. So don't forget about the siblings, the teachers, and the parents and grandparents. And then don't forget the fun stuff, because sometimes the resource a family is looking for is just a way for their family to have fun together out in the community. So some future directions, because this is intended to be a collaboration and a project that continues growing year after year. We'd like to collaborate across departments at Sac State. Sac State has several clinician training programs who have LEND trainees. So for example, physical therapy has a clinic in LEND trainees. Is there a way that we could share resources with each other or combine forces for outreach events? We also want to think about ways to distribute our resource guide beyond the clinicians at Sac State and the families that they serve on campus. One way that we've identified as a possibility is that our NISLA students are regularly involved in some ongoing community service projects, such as going out to health clinics in the community and doing hearing screenings. So perhaps they could start bringing information about the mind and neurodevelopmental disorders to these sessions out in the community. And finally, we'd love to know if there is a way that our students can give back to the mind and to the LEND. So for example, last year, UC Davis hosted the NF RAS Clinic Open House and Mini Symposium, and Dr. Thompson gathered a handful of us students to provide childcare for the families so that the parents could attend the symposium here at the Mind. And that is just one example of something that is really simple, but is fairly easy for our NISLA group to do, gather students for those sorts of one-time events to provide support. All right, any questions or wisdom to share? No? Okay. Thank you.
Thank you, Janice, for the nice introduction. So my LEND project was to, basically, I wanted to look at the early intervention program across California to basically see what's going on, what the trends are like, and what might be helping families get early intervention, and what some of the barriers might be. So a brief overview and background on the Early Start program. Early Start is defined under Title 20 of U.S. Code, which is then funded under Part C of IDEA, the Individuals with Disability Education Act, as Whitney gave us background earlier. And Part C funding is educationally funded. So Early Start program services are an educational model, and they're community-based services and not provided in the same way that a medical model would be. They're for kids 0 to 36 months, and Early Start provides service coordination, screening, assessment for infants, toddlers with disabilities, delays, or at risk. And one of the important things to note about Early Start is that there's an emphasis on parent education along with it, and that services are really supposed to be delivered in a child's natural environments as much as possible, with an emphasis on family-centered care. And so looking at how Part C is delivered in California, because all states are unique and our state is quite large, with California's 58 counties, the services are delivered through 21 regional centers. So in some areas we have many large counties that all go through one regional centers, and then for instance in LA County alone there are 7 different regional centers that provide services. And all the regional centers are independent organizations that are overseen by the Department of Developmental Services. And on average, they serve Early Start serves about 40,000 children annually, which is about 2.5% of California's kids in that age range. So the reason for this research project, besides the fact that as a parent of kids with developmental disabilities and being active in my community, I've been able to see the real benefit for families who have been involved or have had experience with Early Start services. And we know from many studies and articles published, especially with the differing practices of services over age 3, that there is a lot of difference in the way that regional centers function among the 21 different regional centers. And the other reason is with autism and Early Start, there is not a lot that we know, because many children don't receive a diagnosis till close to age 3, and that's when Early Start ends. So that's why I really wanted to dive in and see what I could learn. So this research project, the basic format of it is I contacted every single regional center and contacted all of the Early Start managers who served in similar roles, supervising Early Start. And I was able to conduct structured interviews, and I was able to get 100% participation with all 21 regional centers. So during the structured interviews, I asked about things like referral, how are families hearing about Early Start, who is telling them about the program, which partners are you working with, what's the demand for services, are you seeing an increase, a decrease, what's the eligibility process like, and then access to care, what barriers are you seeing, what things are helping you get families in, and then process changes, any important or notable improvements they're making in process changes. And looking briefly at what I learned from the study, one of the initial learnings is about the overall demand for services. When talking with Early Start coordinators, over 90% said that yes, the demand for Early Start services is going up. And not only is it going up, but it's been going up steadily year after year for the last 5 years. So that was consistent, over 90%. The other 9.5% said, oh, maybe it's been about the same. In the last year, in 2016, they reported over 53,000 families who were referred for intake and evaluation. And then when asking about where are families learning about Early Start, the primary sources are pediatricians, hospitals, and parents. And as you can see, if we're looking to raise awareness, pediatricians are the #1 place where referrals are being made. Other notable sources are family resource centers, the Department of CPS and Family and Children's Services, school districts, preschools, Head Start, daycares. And then looking at autism specifically and early start, some of the notable trends that we found. Here's a quote from one of the early start managers, and this reflects a lot of the data that I found because there's a lot of rich data from conducting so many interviews. I talked to over 38 early start managers within the regional centers, and on average the interviews were close to an hour each, the structured interviews. Many are seeing an increase in children coming in with autism, whether or not they're formally tracking it. When asking about autism, over the half of regional centers say they provide services based on need, not a diagnosis, meaning they're not going to be telling me any specific statistics about how many children have diagnosis, because that's not something they're tracking. Many regional centers say that they don't need to diagnose, or they don't feel they need to diagnose a child because the child will be required to go through a full assessment for ongoing services at age 3. And because they often feel that if a child gets a diagnosis, that would be a barrier to them getting early start services because of insurance requirements. Nearly half of the regional centers report specifically that they have implemented a process to specifically wait until a certain age to diagnose a child, that they're holding off until maybe it's 30 months, 28 months, 33 months. And they're citing a few cited concerns about the reliability of an early diagnosis, or the fact that there could be a similar clinical presentation of children who are born with drug exposures that may look like autism but may not end up being autism. So the next question is, so what data is there that's actually being tracked on autism? I found that 19% of regional centers are tracking formally statistics of likely autism cases or children who are diagnosed with autism. So that's only about 1/5 of the regional centers who are keeping that data. And of those regional centers, the majority are really just keeping data year to year, but do not have anything significant enough to show a trend on what's increasing or decreasing. But one of the regional centers who has been tracking a significant amount of data on autism for a long period was able to show that with autism specifically, the autism referrals have doubled in the last 6 years. They've tripled in the last 10 years. And one of the other questions that I asked all of the regional centers is, do you require a formal diagnosis in order to access autism services? These are things like behavioral services or anything that might be similar to an ABA service. And here's where you can see a stark difference in the divide in attitudes and processes between the regional centers. Some of them said just unequivocally, yes, of course we require a diagnosis. Others said, no, we really don't want a diagnosis. We don't need a diagnosis. That's not how we operate, and we're not diagnosis driven. We serve children based on needs. And so how this broke down, this question, is that 85% said that no, we do not require a diagnosis, and 15% said yes, we require a diagnosis. And then asking, do you require a full developmental evaluation, and this meaning by a licensed psychologist, in order to access autism-specific services? There was a little more deviation here. 70% said no, some said, well, in some circumstances, depending on the age of a child, if they're close to 3, we might. And then 10% said, yes, of course, no matter what, that's how we do it. And so looking at this, what impact might it have? Because we also, one of the things I also asked about was, what are the wait times specifically for general services for early start, and what are the wait times for autism-specific services? However, there was not much differential in that data because nearly all regional centers say that they are providing their services within the 45-day required regulation timeline. But when asking about whether a full developmental evaluation is required, this is when some of the quantitative data is very valuable, because one of the things that some regional center specifically said is that, well, with the developmental evaluations, we often have a waiting list that's we're booked out about 2 to 3 months because of provider availability and expertise. And we're always looking for more licensed psychologists or experienced psychologists in our area. So when looking at some of how these internal processes work, you can understand how there could be a delay of an additional 2 to 3 months depending on these processes. So then for the regional centers who are not requiring a formal diagnosis, how are they determining eligibility for any type of autism red flags or autism concerns? There are basically 3 main ways that this happens. Children are either coming in with a diagnosis already, and many regional centers reported that this was because there are many children are coming in with a diagnosis through Kaiser in their area. And the second second way is that the agency is doing a brief screening themselves. And the third was basically an internal evaluation process that they've developed that is somewhere between a full developmental evaluation and a brief screening. And when asked about how regional centers are improving their access to autism services, nearly half said that they are using the MCHAT as part of a standard intake process to identify needs, and they're using it to implement standard screening in their area. So this is a general look at a grouping of the main barriers that were mentioned throughout California. And basically these are grouped into the themes, the main themes from coding the responses: parent availability or family hardship, linking providers and families, language barriers, the insurance requirement, and some foster care difficulties. So in looking at parent availability, when looking at this, parent availability can include things like family schedules, families moving from region to region, and the services do not transfer from regional center to regional center. And if you look at this, these numbers, the percentages are the percentage of regional centers who have reported these barriers. So 86% have reported that parent availability is one of their primary barriers to being able to provide timely access to services. Nearly a third said that parent denial was significant. Housing insecurity was also significant, especially in impoverished areas or areas with higher transient populations. And 43% said that a lack of phone or inability to even contact or hear back from a family. And then the difficulties or challenges linking providers with families. One of the most notable things was throughout the state, over and over again, a shortage and lack of physical therapists, occupational therapists, and speech language providers was very notable. And some of that was cited due to rates, and then also provider availability. Either providers were not willing perhaps to take rates, or they were taking other school cases or insurance cases even if they're contracted with the regional center. And then lastly, a few areas cited that they really were having trouble motivating providers to go into locations that providers deemed to be unsafe. And then with the language areas, about 43% of areas in California say that there's a real need for more bilingual providers, and about 71% said that there are identified other language barriers, things like specific dialects. And then the insurance requirement was a barrier reported by 76%. And then foster care education rights, which is a difficulty because many times kids coming through CPS, they do not have permission for that. Speaking to some of the family hardships, talking about migrant families, and some of the ways that regional centers are improving access is by beginning services before or while waiting for the insurance process, rather than waiting for families to wait for their insurance. Tracking where the referral source data is coming from to inform community outreach, and having effective partnerships. So then lastly, just the policy implications. Some of the notable ideas were to look at other state models to provide continuity of services over age 3, so there's not that drop off in services. A need to educate policymakers about the unique structure and parent education benefits of early start, that it's not just a generic service. An increase in awareness on the impact and benefit of early start. We have a lot of research on the return on investment of these programs. And then in order to address language barriers, ideas to provide incentives for training for long-term bilingual providers to specifically provide early start services, and increasing rates, paying providers for transportation time since these services are in-home, and incentives for providers to serve really low resource areas. And then also another really consistent theme was considering to remove the insurance mandate that regional centers make families go through insurance. And then also offering non-traditional service hours for families, and flexibility with parent training requirements to ensure equity and culturally appropriate services. So I have many acknowledgements to my wonderful advisor, Dr. Abenstammer. And are there any questions?
Good morning, everyone. Thank you for taking the time to support us and be here this morning. It was actually quite a journey for me to participate in the LEND program. And I want to take a moment to thank my mentors, Irva, Janice, Sally, Auburn, Lori, Steve, Kathy, Robin, and the LEND co-trainees here to support me through this program, because I could not have done this without you and survived this program this year without you guys. So thank you so much for that. So this project actually was inspired by the stories I had the privilege to hear from families and from service providers throughout the state of California, as well as my own family's journey and support going through the understanding and learning about the California system of care for people with developmental disabilities. So just a brief introduction and program overview. We're going to start with actually the California state definition of what they believe a developmental disability is, because it's quite a little different when we look at the medical definition of what a developmental disability is, but there's some overlap there. So in the state of California, in order to qualify for services, California law defines a developmental disability as a condition that originates before an individual turns 18, continues or be expected to continue indefinitely, and constitutes a substantial impairment in 3 or more of the major life activity, which includes the following list below. And common forms of developmental disabilities that you'll see that is served through the regional centers and through the system in California are disabilities include autism, cerebral palsy, intellectual disability, and epilepsy are the major ones, the commons that we see. So the prevalence within the United States, we noticed that according to the CDC, there's 56.7 million people, about 19% of the US population recorded in 2010 that has a disability, and it's encompassing. So we know that disabilities are not just one. You can't just categorize and put one person as having a disability, so there's a lot of co-occurring from autism, intellectual disabilities, and all these other features, so you can't really sparse out and saying this population has specifically autism or this one specifically has Down syndrome. So it's very hard to sparse out and get the appropriate numbers and the clean data to know who is getting what services. But in 2016, there are about 268,952 active caseloads at the California 21 regional centers combined that are serving just clients from birth all the way through seniors that has an intellectual or developmental disability, just to give you an idea of the caseloads that they're working with. And also in 2016, it was reported that 5,816 cases of autism diagnosis out of the 13,000, a little bit over, consumers served at just the Alta Regional Center alone. So it just gives you an idea of how many were struggling to get the services in California in this particular region. Just a brief introduction of the system of care in California. Like Kirsten had mentioned, there's insurance that needs to be part of that in order to become in service. Part of the regional center is Medi-Cal, which is California's medical assistance program. Approximately 12.5 million people were enrolled in Medi-Cal as of May of 2015, and about 32.4% of California's population. So you can see how many rely on this type of assistance just to get services in the state of California. And part of the system of care in California is a regional center, as Kirsten has mentioned, so I'm not going to go into much details because she gave a wonderful overview of that. But they serve it's a single entry point into the developmental disability service system in California. And there's also the state-operated facilities, which is the developmental centers, because it's all part of the legislative action that happened in 1969, which is the Latterman Act, that proposed to provide these services for the families and the needs and the children within California. So out of that Latterman Act, there's the Department of Developmental Services, who currently operates 3 of the state developmental centers, which are licensed and certified within the state of California to provide these services. Originally there was 4, but 1 had closed down in 2015, and the rest are actually being slated to close by 2020, because they found out through the years that they were not being able to support the families. There was one point there was 3,000 families and individuals actually waiting to get into these centers because they could not have the community supports and the family supports available to them to actually live in the community and at home. So there's huge waiting lists and few issues there. And at these developmental centers, there's lack of training and a lot of barriers to support these individuals who are having a vast array of barriers into accessing health, accessing supports and cares to actually thrive and actually develop in these centers, which that was the main mission and the goal in the beginning. But along the way, it's just a lot of barriers, a lot of issues that cause these deterioration of services within these developmental centers. There's also, now there's a shift in focus more on the home and community-based services in California. It's a waiver program overseen by the Department of Developmental Services. They provide federal funding which match for services that are necessary for achieving these goals. But I'll go into a little bit detail later of the barriers that within these services, within all these 58 different counties in California. There's also the California State Council on Developmental Disabilities, which is, the council includes 13 regional area boards throughout California that provide advocacy public information and program planning and monitoring of these regional centers, as well as all the services in the community to support families and individuals with developmental disabilities. So the project research questions that I focused on to understand the system of care in California and how the clinic, when you get the diagnosis, and how you go back home, and what are the services in the community and supports that can really help these patients thrive, as well as these families support these individuals to really live in the community. So the focus of the questions I kind of look at when I'm looking at the literature review, the review of the policies, the review of the programs and the services. So these are just to give you an idea of the questions that I'm kind of focusing on and the highlights of that and the barriers that we're receiving from families as well as service providers themselves. And the methods that I used for my research project, because it's still in progress, I haven't got all the interviews and all the data, because one of the barriers I found out that was trying to get the data, which I try to look at clean data from these service centers, they only were able to release aggregate data for me, but I couldn't know how they're actually, each regional centers are actually sort of like modifying, how do they categorize autism, how do they categorize all these different disabilities, because each, as Kirsten had mentioned in her review, just looking at the early intervention itself, there's just been difference in training of how to perceive and how to diagnose and what it means to have a diagnosis, and are you accepting that diagnosis or not, and is it from a healthcare provider or is it from a psychologist or from a school system? So where are those resources and what type of data are you actually collecting? So it's very challenging to find that type of resource and try to find the continuity between all the regional centers and agreement on how to collect that data was a challenge in itself. So I end up reviewing a lot of department, the DDS region and regional center reports, which is all aggregated data that I'm sifting through. And I reviewed key federal health and healthcare disparities initiatives because each program and communities end up having a part of the funding to really try to develop their own services, because each community is different and unique in a sense of cultural barriers, language barriers, and service barriers, because we're looking at counties are in rural areas have a different unique set of needs, and counties are in more urban have a different set of needs. So it's very hard to find a common ground of each community, what they actually need, and sift that out and come up with a set of data that we can really compare and contrast all these different communities and barriers that they had need. We also try to review the effectiveness of programs, but then again, the barriers that we found was that there's no consistency of each of the programs because it's unique in the barriers and the way that they collect the data and how they report on that data. And we tried to interview and connect with family members, self-advocates, service providers, and advocacy groups. I end up spending quite some time with parent groups, sibling groups, also from the state council meetings and regional center meetings and board meetings, just attending them to see what projects are they using to really advocate for the services needed within their community setting, and what barriers are coming up when they report during those meetings. So the summary is the findings that I found so far through my project. The key issues that I found were the barriers to health and healthcare access. Because of the insurance, most of the majority of the clients are on Medi-Cal, so they are unable to get access to the appropriate services that they were referred to in the first place, because some of the providers are either not accepting Medi-Cal, or some of the providers are having long wait lists because of the insurance and the health programs not paying for a significant amount of hours in therapy that they have been referred to. And people with disabilities experience health disparities and specific problems with gaining access to appropriate health care, health promotion, health disease prevention, programs and services, because we noticed that there was a lot of comorbidities such as diabetes, gastrointestinal issues with some of the families and throughout the spectrum. As they age, we noticed that there's more and more chronic diseases with people with developmental disabilities as well. And we couldn't find a good set of transition issues from pediatric primary care providers and going into adult medicine. It was very hard to find doctors who were able to treat this population with developmental disabilities. And then people with disabilities frequently lack either health insurance or coverage for necessary services for specialty care, long-term care, prescription medications, because a lot of the mental health medications are just either in a different tier, and there's co-payments that they have to, families would have to pay out of pocket for, which they cannot afford. And there's a lot of different type of medications that they have to provide for that they won't have access to. And then the developmental disability service system challenges itself. There's a lack of coordination between the regional centers and the training, and then actually a warm handoff to providers and the needs of services is another barrier that we found. Another one was limited knowledge and expertise. So the clinical knowledge and specific to developmental disabilities, as well as specific medical conditions that were known to co-occur with disabilities. For one example that I found through literature review as well, was since we have a lot of spectrum within the autism, so we have either high functioning versus very low functioning. We also have sensory processing disorders. So there's a very vast comorbidities that you can say that happens with people with developmental disabilities. And providers, from primary care providers to specialty providers, they're very limited in the training and the knowledge that they would have to really service this population, as you can see the caseloads that come through just the regional center alone. And then conducting actual developmental and behavioral screenings, particularly for transition-age youth and adults, to make the appropriate referral for assessment and medical care has been a barrier for these population that surfaced up from the interviews as well as the lit review. We also noticed that certain skill sets of providers are not, the service providers, not just the healthcare providers, but also the service providers themselves, from the psychologists to the speech language therapists, occupational therapists, physical therapists. The communications and interviewing skills, especially with low functioning people with disabilities or autism that are nonverbal. So the communication and interviewing skills and observational skills to really bring about the assessment that can really help this individual thrive with the services that they need was a challenge. And also the physical examination skills, trying to get the medical assessment, just the basic blood pressure, blood tests and things, just to check if they have a comorbidity of diabetes was a challenge, especially with if they have a sensory processing disorder. It's very hard to get a blood test, get a blood draw on someone who is apprehensive to that type of service. An ability to recognize specific service needs, because each individual needs to get a thorough assessment to understand that. So those are some of the things, and another one was just attitudes. So the next steps for our project, and also to kind of look at, is create opportunities for interdisciplinary training in various settings, more collaboration across the services providers is needed, and to dissolve the silos, because we noticed that each of the system barriers are acting in their silos, from healthcare settings to educational settings to community settings, and leverage funding to build the same programs, because we noticed that there's a lot of programs ending and pilot programs within the communities because of lack of funding and resources, and expand and share more research to the community partners and legislators to understand, to create more policies and more fundings for these programs. So, yeah, so any questions?